So, good evening. Namaste, Sat Shri Akal, Vanakkam, Namaskar. What else can I say? Thank you so much to all of you for joining on time. And we are very happy to host yet another, learning session hosted by Association of Nurse Executives India's Patient Safety Fellows. Just before I invite Dr. Rosaline to address the topic at hand today, let me take you through a short informative slides. Just give me a second. Okay, hope all of you can see my presentation. So these learning sessions are specifically addressed towards actionable evidence-based practices. The ANEI Patient Safety Fellowship is being done in collaboration with Patient Safety Movement Foundation, USA. And they have come out with the entire list of, AEBPs, that means actionable evidence-based practices. And we are referring to these documents, and the fellows are referring to more such documents and putting together the current evidence that is available around the best practices on the topic that we are discussing. And from January, we have brought different topics, and now we are in the month of July. And today it is about catheter-associated urinary tract infection. When I used to talk about data from Indian continent, I always used to say we don't have much data. So I just thought, let me Google and see what happens when I put this question on the Google Baba. So you can see here, I'm sure that you can see this page that I'm showing you from Google because I'm able to see that in my mobile. The International Nosocomial Infection Control Consortium reports the prevalence of hospital-acquired infection is 9.06. Let's say 9 infections per 1,000 ICU patient days, and the rate can be 4.4 to 83.9% across different hospitals in India, which is considerably higher than any other country. So now this is another one on 19th June 2023, which I'm seeing it for the first time. I'm just showing this to all of you. India among top countries for hospital acquired resistant infections, because 136 million such infections globally, and China, Pakistan, India bear highest burden. No, I don't need to, show you anything more here, just to say that we are definitely having a lot of problem related to hospital-acquired infection. And the topics that we are discussing is to help you to find the best practices that can be put in place. Very quickly, what is CBP? It's a process used to review. Somebody else is doing all this. They review, they analyze, translate the latest scientific evidence, and they tell, okay, if you do all these things together, you can keep your hospital acquired infection. So this EBP can be not only around infection prevention, for any processes in the hospital, there will be evidence-based practice. So you can definitely look into that. If you want to do a quality improvement project around any topic, it's a good idea to look for evidence. Who else has done these studies? Who else is recommending that this worked well? Unfortunately, in India, if you look for these practices that works for Indian settings in Indian hospitals, you may not find, because we do not publish them. So they are not there. So we need to do more around research and publishing any EVP. Okay. Now, I'm very, very happy to announce that our annual ANEI Patient Safety Conference is decided to be held on 27 September 2024 at MS Ramaiah College of Nursing, Bangalore. All of you are invited to join us on 27. Mark your calendar. and we will definitely come back to you with details. So just save the, save your dates, especially for those who have joined us from Karnataka and from nearby states. It might be easy for you to join us. And we are expecting some very, very important, patient safety leaders across the globe. I can tell you Dr. Michael Ramsey, CEO of Patient Safety Movement Foundation, is going to be there. And Dr. Neelam Dhingra, currently with the Joint Commission International. She's the Vice President and the Chief Patient Safety Officer. She just left WHO. She's also going to be there. If not physically, they will definitely be online, because the conference is going to be an hybrid one. So there will be, you can attend in the auditorium, or you can also register online and watch. So the details will come out in a minute. And every year around this time, we also look at the next cohort of patient safety fellows. 3 cohorts are underway. The first cohort has already passed. The second, though the first cohort is still around, helping the subsequent fellows. Second cohort will graduate this year. Third cohort will continue to mentor the fourth cohort. So it's like a relay. We are helping each other to reach there. And I'm really hoping that all the fellows are making a difference wherever that they are working. So the application format and all those things will be coming out, and it is only open to ANEI members. Non-ANEI members cannot apply for this. And there will be some criteria, because we definitely need, people with certain seniority and experience, because this is not for very young nurses, because you need to have certain experience to do a fellowship. All right, so you will get more information in the members group, WhatsApp group, and also the ANEI website. So watch out for that. So coming to today, the topic that Dr. Rosaline is going to discuss is catheter-associated urinary tract infection. And if you look at any evidence, this is the most common hospital-acquired infection in any hospital setting. So I'm very happy to, invite Dr. Rosaline Rachel to address the topic today. Mr. Vinod, who is a fellow from 2021 to 2023, who already graduated, was supposed to be there along with Dr. Rosaline, but due to personal commitments, he's not able to be there. And I will step in. Dr. Rosaline needs my input. I will be definitely available. And the audience here, please feel free to put your questions, your comments into the chat box. So we will look at it towards the end of the session. So next month in August, yet another very important topic, severe hypoglycemia. And I'm very sure most of you who are from hospital setting, you would be knowing that it's a problem that many nurse administrators are also struggle to see that how do we prevent any patients from getting to hypoglycemia. So that will be discussed by Karishma. She's the fellow from last year, and Dr. Vijaya, who was from the first cohort. So they will be doing it together. And usually we try to do it either third or the fourth week on a Thursday, wherever possible. Change a little bit here and there. So that's it for all the announcements. And thank you so much to all of you for being here. We have 76, participants here. It really gives me immense pleasure to know that, more and more nurses are seriously looking at, helping patients and preventing our patients from harm. So thank you so much for being here, Dr. Rosaline. Very, very warm welcome to the session. And now over to you. I will take care of the back end. No.
Okay. Thank you, ma'am. Thank you for that introduction. Ma'am made it easy by giving a small introduction about hospital-acquired infection. So welcome today for the webinar, where we are going to talk about a common infection which each one of us know. Hope I'm audible.
Yes, ma'am.
Okay.
Yes, ma'am, you're audible.
Thank you. Thank you. So can I have some hospital-acquired infections which we commonly undergo in our hospital area. If you could be active in your chat box, I'll appreciate that.
Dr. Rosaline, your video is getting stuck. Hello, can you hear me?
Common
Rosaline, maybe you can stop
hospital-acquired
your video.
infections which we have come across. Yes, ma'am. Yes, ma'am. Yes, ma'am. I can hear.
Your voice is breaking because you are being.
Is my video?
Your video is getting stuck. Can you stop the video and continue to talk?
Okay, I will close my video.
Nice, better now.
Yeah, I
Better.
stopped the video, ma'am. I stopped the video.
Yeah.
Okay, I have seen CAUTI, VAP, catheter-related bloodstream infections, very good. So all the various type of infections which we come across when we are working at our hospital setup, all of you have mentioned, I appreciate for that. Today we will be looking into, let me share the screen. Okay. So today we will be talking about catheter-associated urinary
Dr. Rosaline,
infection,
Dr.
which
Rosaline.
is quite common in our hospital setups. I'm sure each one of you, is my screen visible?
Dr. Rosaline, your voice
Is
is
my
not
screen
clear.
visible?
Screen is visible, but your voice is breaking.
Ma'am, yes, ma'am.
Your voice is breaking. Your connectivity
I
is breaking.
can hear you, ma'am.
No. Your voice is breaking very badly. Hello? Hello, Rosaline, can you hear me? Hello? Hello?
Now, ma'am.
Rosaline, you are not audible. Rosaline, you are not audible. Hello? Can you connect yourself to your mobile data? Maybe that might work better. Hello? I'm sorry, team, that we are having a challenge. Let her come back with the, different connection. Just give us a moment. So we will try to get her back because she's not audible. So that's very, very motivating to see 93 people at 7:15 logged in. Thank you for being here. So I would like to know that any of you here working as ICN in your hospitals? Anyone here? You can say yes in the
Yes,
chat.
ma'am.
Okay, you can put it in the chat box. Thanks, Maria. Anyone else who is working as ICN? It would be good to know that.
Yes, ma'am.
Yeah, just type it in the chat box and say yes, yes. Okay. Nice to know that how many are there. So I'm expecting you would participate, maybe give comments and ask questions, do you all agree that CAUTI is probably the topmost problematic area? Yeah, in your hospital, do you think that CAUTI is the most common and problematic area? I'm just waiting for Dr. Rosaline to join us. Just give us a moment. Yeah, all are saying yes, CAUTI is a challenge. So Let me just check with her if she is having any challenge, because I have to step in and help. Don't go away. We are getting her back. Dr. Rosalind will be back in a moment. Just give us 2 minutes. So she'll be back. Hi, Dr. Rosalind, are you back?
Can you hear me? Sorry about what has happened.
Yes, yes, we can hear you.
Yeah, okay. So thank you for those who responded. So today we will be seeing about the catheter-associated urinary tract infections. Is my screen visible?
Yes.
Yes.
Okay, so thank you, ma'am, for being my mentor, and I apologize for Mr. Vinod, who's not able to join us today. So today we will be talking about catheter-associated infection. Urinary tract infection, as we all are aware, is one of the hospital-acquired infection, and of which 70 to 80% are health-related UTIs due to the insertion of the wrong technique in inserting the catheters. So as we are aware of what CAUTI or catheter-associated urinary infection is, it is the presence of bacteria which is in the urine. For a catheterized patient, we commonly call it as the catheter-associated urinary infection. So if we see the percentage, earlier I have said 70 to 80% are health-related UTIs, and here I have given you 40% of the hospital is due to the hospital acquired, or it's a nosocomial infection, which clearly states that it is either the wrong technique or not using aseptic precautions, or it can be due to the wrong way of emptying or use of the catheter when the patient is hospitalized. So this could be the common reasons why a patient develops when he is in the hospital. We need to understand that sometimes the patient comes into the hospital with a catheter because of prolonged stay with a catheter at home, or he could be shifted from one hospital to our hospital and he comes in with an infection. So this is also accounted for a hospital acquired infection. So the main concept why these CAUTI comes in when we insert a catheter is due to the formation of a biofilm. I will be explaining to you how this biofilm is formed when we insert a catheter in a short while. So this indwelling catheter is always a foreign body or a foreign organism which is present inside the bladder, which is a sterile environment. So this particular biofilm forms around the catheter, which harbors, or it's a good place for the organisms to multiply and stay in. So due to this particular concept, what happens is CAUTI has been associated with increased morbidity and mortality. I'm sure you will agree with me. Any patient who stays in the hospital for a prolonged period of time with a catheter, maybe it is a required one, or sometimes we leave thinking that the patient is bedridden and we may leave it for a day or two more. We need to remember that when a patient more than 2 days, when he is on a catheter, the percentage of infection is 3 to 10%. And when the patient stays with a catheter for 1 week, every chance of CAUTI is 25%. And for a month, if a patient is on a catheter, it is 100%. So we need to remember that the shorter the stay, number one is only if it is necessary, we will catheterize. Number two, shorter number of days, even if it has to be catheterized, shorter number of days. So this can prevent the morbidity and mortality. And remember, when the patient is having an infection, he needs to stay longer. That increases the healthcare cost and the length of the stay for the patient. It is going to have a pinch upon the patient's pocket. So keeping all this in mind, and we are dealing about our patients who need to be taken care, and patient safety is our concern. So that's why today we are discussing about CAUTI. So what are the classifications? Can somebody in the chat box say what are the different classifications which we come across in CAUTI? Can I give a clue? 2 types. Any guesses?
Ma'am,
Okay.
SUTI and ABUTI.
Very good, very good. Thank you. So we have 2 types of, the classification is 2. One is asymptomatic and the other one is a symptomatic one. So we say catheter-associated asymptomatic bacteria. We do not have any signs and symptoms for the patient with a urinary tract infection, but still there is organism, but he doesn't manifest. And the other one is where we see signs and symptoms of bacteria, where the patient has 1 or 2 symptoms present. And then we also, when we do a urine analysis, we find that the count, we say that the threshold of bacteria, it means that is, it goes above 1,000 to about 1 lakh. So between this, we call it as when the patient has more than 1,000 is, we call it as a symptomatic. And when it is go above, sometimes they do not manifest any type of symptoms here. So these are the 2 common classifications. And what are some of the risk factors? Can we classify the risk factors and say these patients would be developing? Any guesses? What are the risk factors? Okay, let me give you clues. 3 types of risk factors can come in. One is patient related. The second one is device related. And the third one is caregiver related. So already we have seen that it is a hospital acquired one. So related to the patient and related to the device and the caregiver, there are risk factors which is being classified. When it comes to related to the patient, usually we say it is the female patient. Why female patients? It is because of the short urethra and the accessibility between the urethra and the anus. So there could be a chances of contamination. Any patients who's got any serious underlying infections and age above 50 due to poor immobility or hemostasis, it can happen. And diabetic patients are more prone. Elevated creatinine patients, any type of kidney disorders if they have, poor personal hygiene, all of you will accept that. And then urethral colonization. All of us have some amount of bacteria being present and we are asymptomatic. But these patients, when a catheter is being inserted, can very easily go in for a CAUTI. Then fecal incontinences. Patients who are bedridden and have fecal incontinence can also develop this problem. So these are all coming under the risk factor of the patient. And the second risk factor would be device-related risk factors. The duration, how long the patient is on catheter, it also matters. As I told you, shorter the period, better for the catheter to stay with the patient. And the type of catheterization we use on the patient, and for a long term, the type of material which we use for catheterizing the patient also matters. So those are device-related risk factors. And the last one is caregiver-related risk factor. So emergency, when we are taking a patient for catheterization, at some point of time, when our hand wash or any type of aseptic precautions are compromised, then the patient can land up with CAUTI, and improper techniques of failure of any adherence to aseptic precautions. Then going on to the signs and symptoms. All of us are aware, many times the patient is asymptomatic, we see, and sometimes we ignore pain for these patients. Pain, that is suprapubic tenderness, costovertebral angle pain, the patient can have urinary urgencies, frequency of urine or dysuria, peripheral leukocytosis, and pyuria are, when it goes into pyuria, it is a severe type of CAUTI. So usually the patient manifests as fever and urinary urgency and pain. These are common things which they manifest. So that's a typical sign and symptom of CAUTI. Now, looking into this picture, you will be able to say this is not only related to catheter, because the patient is catheterized. Again, I want to stress, only when it is necessary, we will catheterize the patient. And how long the patient is on catheter, all the type of complications being developed in this patient. How does it develop? So they are prone to have infections. They are prone to have pressure ulcers because the urinary catheter is in place. There is less mobility for the patient. So due to this, the patient can have a fall because he is lying down for a long period of time. And there is an increased stay when the patient is having any type of infection. And due to the discomfort, having a catheter in situ, it causes so much of discomfort to the patient. And it can even cause trauma to the patient due to the pressure or the pull which we give when we are shifting the patient and caring for the patient. It can happen. And finally, when the patient is having CAUTI, we need go for antimicrobial drugs, which can lead to adverse drug events when the patient. So isn't this a patient safety issue? Not just CAUTI. We are today not talking only about CAUTI. It is more related to the patient safety, which covers all areas. The patient becomes immobile, he has a fall, and then the length of stay. Everything is being affected for the patient when he is having CAUTI. We come across is very common is E. coli. Due to the uropathogenic E. coli are quite common because of the closer proximity, there could be a contamination. And when there is a contamination and when we are inserting in the urinary tract, this can push it into the bladder. And this is for a short term, we see this organism, and even Pseudomonas is quite common. And other organisms, it depends on the type of hospital and the way we have inserted. And in long-term patients, what we see is the protease is the common type of infection. Protease bacteria or due to candid infections also, this can happen. Any other organisms which you have come across when your patient was ruled out for CAUTI? Yes, anyone?
Capsula, E. coli.
Yes. So these are common. Good. So Klebsiella E. coli is the usual thing, and also protease infections we see. Right. Then we'll go on to the pathogenesis. So this picture is simple to understand. Where are the sites and how do we introduce infection into the patients? So the first thing which I told you is the biofilm. The first part of it when I was talking to you about the biofilm. So the urethra itself harbors some amount of pathogens due to the close proximity, due to the contamination, or our body itself can have. Being an asymptomatic, the patient may harbor certain organisms in the urethra. So in the process of inserting the catheter, we will use an aseptic precaution and we will insert. But when the Foley's catheter is entering into the bladder, we could push in some amount of infection because it was present in the urethra and we are not aware, though we have thoroughly cleaned the area and we do it. So due to the urethral meatus, the catheter junction harbors this organism, and you can see this little square which is put around the catheter. So you have the balloon here, and this balloon and this little triangle here, what we see is that is the place where a mucoid-like gel develops around the Foley's catheter, and all the organism very easily cling to each other and they form a colony. That's why we call it as colonization. So they form into clusters and colony, because independently these organisms, when they float around in the bladder, they can very easily be pushed out along with the urine. So they cling to each other and form a colony. And between this urethral meatus and the catheter junction, it's a very convenient place for the organism to thrive. The second thing is the catheter drainage tubing junction. So where the tubing gets inserted, we have the area where it forms into a, so this is how we push in through this, we push in the water to keep the Foley's catheter in place. And this is the, so this particular place is again a very convenient place for organisms to quietly multiply there. And it can, when you're holding on to the uro bag higher above the bladder, this organism can very easily be pushed into the bladder. And the third area is the drainage tubing. When we are having the drainage tubing, when the drainage tubing is above, then that can also push in from the bag, the urine can backflow. Then the outflow drain. So many times the outflow drains are secured for our patients, but during the shifting, when we are sending the patient to theater or from ICU to the ward, we keep the bag on the trolley between the thigh of the patient and we send. Sometimes the timing and the shifting time, this backflow can happen. And if the bag is not changed and if the bag is contaminated, this could happen. These are the 4 portal of entry for the organisms to enter. Then going on to the extraluminal and intraluminal spread. So in the catheter, if you see this tip, when we are doing the insertion, I told you there could be extraluminal is those which are present endogenously in the urethra that can push the organism inside, or when you are trying to do a manipulation to push in the catheter, or when there is any type of late by capillary action, we wait for the urine to drain in, so we keep adjusting, and then the ascending perennial bacteria which are present also can go in. So these are all the, so when you see, it accounts for about 2/3 of the cases are due to the extraluminal. There could be a introduction of the organism. And then the intraluminal part of it, it is 1/3 of the cases. This is due to the break in the drainage system. So when you are shifting, when the uro bag is, pulled out when you are shifting the patient or something, and the closed circuit is not happens, and reflux of urine from the bag is also a common thing. Am I clear so far? Ma'am, would you like to add something up to this? If I've missed something?
No, perfect. Please,
Okay.
carry on.
Okay. Thank you, ma'am. Another area where this is true white stones. These true white stones is something when the patient comes to us, we do not know how many of our patients have a calculi. So these true white stones, when present inside, Proteus bacteria tries to, this is due to the Proteus bacteria around this true white stone. What happens is it changes the acidic to alkaline. The pH nature of the urine is changed because of this true white stone being present. So this is, we do not know, this is extraluminal, something present inside, and we are inserting a catheter because the patient goes for surgery. So because of the presence of this and the insertion of this, the Proteus organism tend to change the alkaline nature. So that also can cause a CAUTI. Okay, so why does an indwelling catheter cause risk for an UTI? These are things which I have already told you. That is number 2, the duration. How many days we keep the patient on catheter? Is it really necessary? Are we doing an assessment on the patient? And are we reminding our professionals, our doctors, whether the urinary catheter can be removed? The patient is good enough to void on by himself. Then the pressure due to the decreased mucosal blood flow. When we are changing the patient, when he's lying down in the same position for a long time, sometimes we secure the Foley's catheter for men on the suprapubic region, on the female for the thigh, according to our convenience when we are securing, and it is kinked or there is some amount of there is some mucosal disruption happening, or if there is an impaired mucin secretion formation, all this can also lead to a CAUTI. Then when we are doing the emptying of the bag, Euro bags, when we are when we do a pressure, when we pull, or when any type of shearing effect happens, that also causes, and due to the biofilm formation, CAUTI can be a common factor. Okay, so this is a simple CAS concept of how we diagnose. How do we say that a patient has got a bacteria? Is we need to remember, normally urine is sterile, but when the patient is voiding through the genital tract, common commensals which are present on the tract makes the urine to be contaminated. So that's the reason we say about midstream urine. Hope you remember about the importance of why we need to collect a midstream urine. Even for a urine analysis, we tell the patient, allow the urine to pass in and pop, because the urine is basically in a sterile nature. So when the patient, when we are doing a urine analysis on the patient, how do we differentiate is using this CAS concept is less than 10,000 to 1 lakh. So this is a, it's a spectrum. You need to remember between 10,000 to 1 lakh when the patient, so when the patient has got less than 10,000 per milliliter, when we say milliliter, that is the colony forming agents, how many colonies it can form when we take 1 milliliter and we examine. So we say when it is less than 10,000, there is some amount of contamination. The patient may be asymptomatic. Between 10,000 to 1 lakh, we are indecisive. So if you feel that the patient has got certain signs and symptoms and you want to really look into whether this patient has got an infection, we need to repeat it and then decide upon whether we need to go for a treatment, because still the patient may be asymptomatic. Whereas if it is 1 lakh colony formation is there, then we need to have, we say that there is a significant bacteria in the patient. So this we need to remember when we are diagnosing the patient. So now coming on, all these things are quite common and you will be remembering all what I have told you because we have all studied, we are just brushing up. The prevention part is something which we need to understand. Regular training of every healthcare workers. They should be a privileged person when they are inserting the catheter. Not everybody who is working in the hospital can do the catheterization. That we need to remember, and we need to choose the correct catheter. We need to use whether appropriate indications are there, whether any urinary, whether the patient has got any voiding difficulties, whether the patient's measurement has to be really made, and based on that you need to decide upon the fluid for the patient, and then you are inserting a catheter. Is there a right indication? That is very important. And use of long surgical procedures, we normally insert a catheter even for a patient who is going for CABG or any type of long-term procedures, or even for cesarean section. Just for 24 hours the mother will be on catheter, but still, is it a right need for the patient? Inappropriate intraoperative monitoring of urinary output you want to do. And for the comfort, for the end of the life care, the patient is all in a dying stage, and due to the incontinence, or he's wetting the bed, and there could be a chance of a pressure ulcers because of the soakage. All these things also we may insert, but is it really needed? The assessment of the patient is very, very important to know whether catheters is really required. So the next thing is avoid insertion. Already I told you, as much as possible, assess the patient, look in for all these indications, whether it is really required. As much as possible, try not to catheterize. If it is really necessary, catheterize for a day or two and keep assessing. Every shift we need to assess, and we need to remove the catheter at an earlier pace so that the patient does not have a problem. Or we can go in for intermittent catheterization when the patient has got any type of injuries, or to prevent further, if the patient has got any type of infections, to prevent further complications, we can do it. Measures after the catheterization. What are the things which we need to do is, it is very important to maintain a closed drainage system. So we need to understand that at no point of time there will be clamping done and then the patient's urobag is removed. We wait for the urobag to be connected, or sometimes when the patient has to be ambulated, we see they clamp the catheter and tie it along with the patient's gown, and then the patient keeps walking. Until then, there's a portal of entry. So always the urobag need to be connected. That is very important. Then the bag should be below the bladder. So this we need to remember whenever we ask our students or any attenders, when they are helping the patient for ambulation, we need to keep reminding them that the bag should be below the bladder, and leg bags can also be tied. And emptying, we need to use an alcohol swab to the outlet so that we do not introduce any organisms. Then you need to use a good collection container when you are using. Keep everything ready and then open up the bag. And then whenever we are emptying and when we are collecting a sample, we need to remember that. And hand hygiene before, after, and touching any patient unit. We need to remember hand hygiene is something very important. And the meatal care. Washing the area with soap and water. If it is desirable, you can do it, or using a betadine swab, we can clean the meatal area. Frequent washing and ulcerations can also lead to infection. So frequent washing is not permitted, but we need to clean the meatal area. Then early removal of catheter, and when we are removing catheter also, it's very important to use aseptic precautions. Then bladder irrigation, only if it is indicated, we will do a bladder irrigation. These are measures, preventive measures, which we need to remember when the patient after his catheterization process. So this is a quick recap of, your hand washing techniques. I need not have to explain to you before touching the patient.
Rosaline,
Yes,
I'm sorry, I will just butt in for a second. As per the CDC guidelines, no betadine, no antiseptic for meatal care. It is only soap and water as per the CDC recommendation. No betadine, no antiseptic to be used. Hello, could you hear that, Rosaline?
okay. Yes, ma'am. Yes.
Okay. I'm going to run a short poll to ask what is your practice, okay? So let's see how the, people will be responding. So I'll just share, but you can continue, Dr. Rosaline. Thank you.
Okay, so this particular picture is just to remind you that hand washing urinary catheter. So any type of insertions which we do, hospital acquired infection, we need to remember before touching the patient, before the procedure, after we come across, after emptying the urobag or any type of body fluids, after touching the patient or after touching any patient environment. So these 5 points and the 5 hand movements which we use for hand washing, we need to always remember to prevent hospital-acquired infection. And especially today, we are concentrating on CAUTI. So even during catheterization, we need to remember that. Now we are going on to the care bundles, which will again be certain repetitions, but I hope that will, brush your memory on this. So insertion, we need to verify whether we need catheterization or not. And when we are inserting the catheter, use aseptic precautions, and we need to maintain urinary catheter based on guidelines. And for the maintenance bundle, we need to remember daily assessment of the patient, whether the patient the catheter can be removed at the earliest. We have to tamper the evidence seal is intact. Make sure the closed circuit is always being maintained, especially when we are shifting the patient and when we are ambulating the patient. We need to remember that catheters should be secured to the patient. It is very important, not to the IV stand or somewhere, whatever is available, or when the patient is sitting on the chair. When you're ambulating in the ICU and making the patient to sit down on the chair, it should be secured. Never leave it on the floor. And as I said, hand hygiene, daily meatal hygiene with soap and water, and drainage bag emptied using a clean container, and unobstructed flow should be maintained. Kinking of the urinary catheter is very common when the patient is turning or when we are positioning the patient. We need to check whether the urine is in flow. So this is the important care bundle which you need to remember, and it should be a checklist each time when we go near the patient and we come away from the patient, we need to remember these points. Okay, so now we are going to certain acronyms which will make you to remember. This could again be a repetition, but still easy to remember when we are teaching our novice nurses. Closed system, catheter selection, and consider alternatives. If it is necessary, only we catheterize. The second thing is aseptic management, universal standard precautions, and T stands for tie or secure the catheter to the patient and the tubing to the bed. And I stands for indication. Are we using it according to the indication, and are we discontinuing once the need is over? Make sure obstruction free and specimen from the sampling port, and no dependent loops. No dependent loops is, sometimes a loop of the catheter hangs down and that could cause stasis. And then if there is a backflow, that could cause. So it should be an unhindered, and where necessary, we need to secure so that there is no dependent loops available. So this is one acronym for you to remember for a CAUTI bundle, that is caution. And the second one is, if you suspect a CAUTI, we need to discuss and we need to do a urine analysis and culture sensitivity if it is appropriate. Never wait longer until the patient's manifestations are severe. So we need to do a urine analysis. Then when you are using the specimen, when you're collecting the specimen, ensure that before antibiotic therapy, we collect the urine specimen. It has to be sent on time. Never keep it for a long period of time for sending. And if there is nobody to take it, it has to be refrigerated, and immediately when the attender comes in, it has to be sent. Never leave it outside longer before the analysis. And then the specimen collection, when you're using from the Foley's catheter, it has to be cleaned and allow the urine to flow out. Then the midstream urine will be collected. That is the right way of collecting the urine sample. And the second one is CAUTI to prevent CAUTI. So this, we found it an impressive one for you to again remember, CAUTI to prevent CAUTI. So the first thing is, the symbol here shows that to the maximum, avoid catheterization and urobag being connected to the patient. The second thing is, try to make the patient a mobile patient so that they will be able to move around and void by themselves. If these two things are not possible, we need to look into the indication for an indwelling catheter. So I listed out all the different indications which a patient may require when he has to be assisted in the healing process for any type of sacral or perineal wound is there, or if the patient is needs any acute urinary retention or bladder outlet obstruction is there. So if these indications are there, we have to catheterize. If not, catheterization should never be done. Again, C stands for catheter removal. At the earliest, within 24 hours, if the patient is ambulatory, try to remove the catheter and follow the precautions, and make sure to remember to remove the catheter at the earliest, using aseptic precaution at all times when we are inserting, caring for the patient and removing, and regular assessments to know whether the catheter should be in situ. Is it really necessary? Has to be done during every shift. I told you. Training for catheter care. It is very important that whoever is working with the patient, it could be a doctor, a resident who's there, or it could be a novice nurse, make sure the CAUTI bundle is discussed with them. Make sure we observe how they are doing it. This is very important to prevent CAUTI for the patients, and also how the drainage system is being done, whether it is being assessed properly. We need to observe in the novice nurses. And for incontinence care planning has to be done. How are we going to train the patient so that he can feel the bladder fullness, and at the earliest we will be able to remove the catheter. So all these precautions when we are taking, CAUTI will prevent CAUTI. So this is a very simple thing for each one of us to remember. So we need to teach our fellow nurses. So this is another acronym is also given. So third acronym I'm giving, no CAUTI. So again, for no CAUTI, we say that need for catheter to be assessed, obtain patient concern, or often offer patient education. Many times the patients who have to be bedridden goes home with a catheter. So it is very important that we educate our bystanders about how they have to care for a patient at home and how often they have to come in for change of catheter and the urobag. And when the urobag has any type of sediments coming in, and they need to immediately report. So this has to be, education has to be done. And C stands for competency. I told you, every person who insert, only a privileged person can insert the catheter. Then aseptic precaution, make sure the tube is unobstructed. There should be timely removal and documentation. So when we are removing the catheter, if necessary, we need to repeat a urine analysis if we find any symptoms of urinary infections on the patient. And the I stands for infection risk. Remember, any patient who's got a catheter has got a risk of infection. So we need to monitor even after the catheter is being removed. So these three acronyms, I hope you will remember. And another, as I come to the conclusion, I want to just say that disrupting the life cycle of a urinary catheter, 0 step is no catheter at all. Only if it is required, we will do it. Number 2 is using aseptic precautions, then maintaining awareness and proper catheter and prompt catheter removal. So these things, so 0 effect is no catheters. If we are inserting aseptic precaution, shorter duration and prompt removal of the catheter prevents the patient from having CAUTI. So in summary, all of you will agree with me, CAUTI is one of the leading hospital-acquired infections which we come across. We have got catheter care bundles being available. We need to remember, for a shorter stay of the patient at the hospital, without a catheter, we should be able to manage. If at all it is inserted, we need to remove the catheter at the earliest. And at every step of patient care, we need to ensure that the uro bag is in place and it is in flow. So all these things can definitely prevent CAUTI for our patients, whereby improve the patient safety, and also as an overall, the patient's number of hospital days stay also will be reduced when we do this. So thank you for patient listening. Any questions? Ma'am, kindly add if I missed out anything.
Thank you, Dr. Ruslan. Thank you very much. There are a few questions here, and I have also a few questions to ask the audience. Maybe we can stop sharing. So one of the questions which repeatedly came, someone answered also, is that whether there is any indication to change the catheter on a routine basis. The answer, as per the CDC, there is no recommendation. The recommendation is that if you anticipate the patient is going to have a long-term catheter, you decide to use a silicone to start with. So it does not say that after 14 days, 16 days, shift to silicone. That is not the recommendation. Idea is to anticipate and then put a silicone. And if you put a silicone, you can leave it for longer period of time. All right. That is one. So obviously there is nothing like somebody answered 16 days. Please, there is no recommendation. Always remember, evidence-based practice is not what you write or I write as protocol. They are not evidence-based practices. Evidence-based practices come from authorities and, literature reviews, from there they summarize. Now we follow CDC, US, and that is where, so then they put all the interventions as, what classification, 1A, 1B, 1C. I'm sure that many of you know that, the strength of evidence. So from there, 1A's are it must be followed. 1B is yes, 1C is like, okay, dicey, not very sure. And sometimes CDC will say there is no evidence, but it is recommended. They can't give you the evidence. So that is one. Definitely CDC talks about not clamping the catheter. That Dr. Rosalind already mentioned, that we do not want stasis of when a catheter, stasis means stagnation of urine in the bladder. So when you clamp, it is actually asking the urine to sit in the bladder for longer period of time. And all the, reasons, the biofilm, why they will grow fast in the urine, in the bladder, everything has been explained. So there is no need to clamp the catheter. Now, most of the drainage bags, they come with a collection port. So you are supposed to disinfect, like scrub that area with 70% alcohol, allow it to dry. You can put a syringe and take what you need for the sample. And the volume of urine that you need is very less. We think that, you have to fill up the bottle with urine. It is not required. But if you are doing a large volume collection that you want to, measure the what you call creatinine clearance 24 hours or something like that, you are supposed to put a fresh bag. Put a fresh bag, and then you can bag the entire thing from the bag itself, So it is very important to remember these things, The recommendation from CDC about the catheter care or the metal care is only soap and water. Okay. Before removing catheter, the clamping is not at all recommended. Because if you go back and read CDC, these are all old, outdated practices. Even I have done that. We call it as bladder training and all this stuff. It is not recommended. It does not help because it actually leads to more complications. So there is no need to clamp the catheter for any reason. That is one. I'm just looking at the questions that came here. Okay. Someone asked that is cell present in the urine. Please understand, definition of CAUTI has got multiple things to be ticked off. The colony forming unit is only one aspect of deciding patient has got CAUTI. There are other symptoms that needs to be, there will be 2 or 3 criteria. This is not the place that I can explain to you the criteria for deciding CAUTI. Everything is crystal clear in the CDC. So only if you take this and this and this, there is CAUTI. Just having a colony forming unit is not. Jarin Rajan, mute yourself. So that's important. So CAUTI is not the presence of any bacteria or yeast or anything. It is not necessarily. So in the beginning, I think Dr. Rosalind mentioned about asymptomatic bacteriuria, where you have bacteria, but patient is not showing any symptoms of UTI. So that's because they don't fit into the criteria. And I'm sure the ICNs who are sitting here, they appreciate what I'm saying. So I would like you to check and do poll. I'm just going to launch the poll. So please take the poll. So we will just know what is the common practice that all of us have when it comes to urinary catheter care or metal care. Just click whatever is your, practice. There is no right and wrong here. I just gave you 3 options. You can just select whatever that you are doing. And there is no name that comes up. So no need to worry. You can be totally candid. I would request, we have 122 people here. If all of you can, just answer, it gives us a fair bit of idea what is the prevalent practice in Indian hospitals. So I would like to see that. So I would like, at least those who are answering soap and water, I would like, if you're ready to share your practice, I'll be happy to listen to you that, how do you manage to do this soap and water care? What is the protocol? How do you standardize the protocol? That all nurses, they do the same thing. And saline also. Betadine, I will say, please stop. There is no discussion about that. Whoever is answering betadine, please learn from today's webinar that there is no evidence-based practice which supports betadine. There is no EBP around saline also, but I kind of know why the saline is being used because I was also forced to use saline after we introduced soap and water. If the time permits, yeah, we can take few more minutes because we lost few minutes when Dr. Rosalind lost connection. So we will use those few minutes to get this clarity around this, because this is one area that I kept on thinking about it. What is it that we can do so that the catheter care becomes the right uh, procedure for all our patients in our hospital? So we have got 62 responses, which is like 50% of the people. Okay. So ambulatory patients with catheter use soap and water, and saline for bedridden patients. So I would now I'm going to end the poll, and I will also share the results so you can see. 32% soap and water, 49% saline, and betadine 18%. So definitely 18%, please stop using the betadine. You can always go to CDC and look for the guidelines. That is what you're going to convince your organization or your hospital infection control committee. It is not about that we heard this in the webinar, Dr. Rosalind was telling. No, there is always evidence available. So you speak as per the guidelines, which is provided by authorities that we follow. That is very important. Okay. So let's stop sharing, and let me now invite anyone who is using soap and water to share with us that what kind of procedure have you, institutionalized? That means everybody does the same procedure. Can someone share? Hello. Hello, friends. Sharing is caring, and we will learn from each other. That's your protocol. I'm just asking you to share whatever that you are doing.
Good evening, ma'am.
Good evening.
Ma'am, Karishma here. So thank you, Rosalind ma'am, for sharing such a good webinar. We could learn many things. Ma'am, in our hospital, in our practice, actually we when we discuss in our HIC committee meeting before starting that it is a soap and water as per the CDC. However, ma'am, there were some issues with the water, so we have started using distilled water. So
Okay.
not that plain water, and there were some issues with the infrastructure to get the RO water. So that is the reason we are using distilled water, ma'am.
So you are what I hear is that your regular water was not safe enough, but the same water you use for bath, right? Hello.
Yes, ma'am. Yes, ma'am.
So did you get evidence to say that if you use the bath water, patients will develop more CAUTI, or you just assumed?
Ma'am, there was the water culture report showed something, so it was decided in the meeting, and then we come to and practice of using this distilled water.
But there is no evidence.
Yes, ma'am. No evidence.
It is kind of a, it's a self-imposed guideline. You have done that in your hospital because your water culture, and the same water is being used to give bath to the patients, correct?
Yes, ma'am. That for bath we have that sponge and that we use.
Wipes, the famous pocha. Nowadays, if you ask patient, did you get your bath? Yes, pocha laga ke gaye the. That means, we are just wiping the patient. Okay, we'll come to that wipes also in a minute. Okay.
Okay.
Thank you, Karishma, for sharing candidly why you opted for distilled water. Now, I would like to hear from anyone who is using soap and water, regular water and soap, and then any saline. Why did you opt for saline? Guys, 120 people are sitting here. Somebody can definitely share.
Ma'am,
Correct?
soap and water, no few amount of soap is there itself. I mean, by nurses forget or whatever that causes patients irritation.
Okay, so that's thanks, Maria. What Maria is telling, that when you use soap and water, if you don't wash it away completely, the soap will dry up and that can lead to patients' irritation and itching. Am I right, Maria? Hello? Hello, am I right, Maria? I think
Yes,
that's
ma'am. Yes, ma'am. Yes, ma'am. Exactly.
okay. So now, of course, when I was in Fortis, obviously this guideline came and we said, okay, we will start with soap and water. So we told them that, when you're giving bath to patient, there were no wipes at that time. We were giving basin, water, soap, sponge cloth, etc., etc. So we said, when you're giving bath to the patient, just wash the perineal area, meatus, everything with the clean water and soap, and you put the bedpan underneath, wash the patient, and then clean it with water so that there is no soap remaining, and then dry the patient. This is just like any sponge bath. We started this, but then I started getting complaints. Patients started complaining of itching, and most of the complaints came from female patients. And the reasons, you are aware of the reasons. So I actually went to see the patients. I said, okay, let me see why are they complaining of itching. So I went to one patient and she said that, I have my private area is itching too much is because of the catheter, because they think it's because of the catheter. So I told her, ma'am, can I just see the area? So when I pulled the curtain and when I looked at the perineum, I saw that, this entire soap marks are there. The soap is not washed away. Because of that, we shifted to normal saline. And we also made sure that, they were using, the sterile bowls, though it is not a sterile procedure, please understand. Catheter insertion is a sterile procedure where you have to do betadine. So when it comes to catheter insertion, there is no EBP for, having 2% practice. But I would say in Indian setting, it is a good idea to have 2 people doing the catheterization. The person who is doing the catheterization should be totally sterile so that they don't contaminate anything. And the assistant can make sure that everything is, maintained sterile. Because when one person, I remember someone telling, somebody goes with one catheter and one gloves and say, I will put the catheter and come. That definitely is a big no, no, no. Obviously, that can lead. See, not every patient to whom we break any infection prevention practices will end up having a hospital-acquired infection. But vulnerable patient, we don't know who will get it. I don't like to be one of that patient, and I'm sure that you don't like to be one of that patient. But we know that 1 in 25 patients, 1 in 25 to 30 patients will definitely get a hospital-acquired infection. There will be harm done to the patient. So we don't want that to happen, correct? So saline, betadine is definitely no. Please take it from here and you can go and search in the internet. The CDC recommendation will not talk about betadine. So while I had been doing this infection control, infection control nurses training, every time all these questions come, all these answers also come. So I keep thinking that, when you actually look at how catheter care is, demonstrated in the YouTubes, in the hospitals in the West, where certified nursing assistants are trained how to do catheter care, they actually have a, towel that they use, and they do the folding. Then each fold is used to do one action. That is how they give the care. Okay. When I saw that, and I used to wonder that, we are using these wipes, right, to give sponge bath to the patient. Why not find out from the company whether whatever ingredient is there in the wipe, is it compatible with the material that is used in the Foley's catheter? If they are compatible, you can actually use the wipes while you are giving bath to the patient. And we can generate our own EBP. So I am just giving this idea. This is not an EBP. It is not there. But we have the evidence-based practice which says soap and water. And instead of soap and water bath, you are using bath wipes, correct? The
Yes,
rationale
ma'am.
is very easy to
Yes, ma'am.
understand. Only you need to find out from the company that what are the ingredients which are used in the wipes. They are not straightforward soap. And what whether those ingredients are compatible with the material. HP, please mute yourself. Please, those who come for such sessions, no, please understand. You must look at your screen and see that, you remain muted. Please do not disturb others. Sometimes I'm not even able to mute people, because of whatever reason. The only way I can do is to remove them from the class. That's it. I have just now removed HP because, sorry, something fell down here. All right. So I'm leaving this, idea with you. If anybody wants to take it up, I think we just need guidance to follow the evidence-based practice process. And that process also is available. You can use the John Hopkins tool to follow a process and then create, because you want to, this is a question, no? You're asking, can I use the bath wipes to give my regular catheter and metal care? One need to have sample size and all that stuff, then you will come to know whether it is useful, and it becomes very easy for nurses. Otherwise, there is never-ending confusion. Where do I put the saline? The saline also is not that safe, because saline also, if it dries, it can lead to dryness and itching, correct? You put saline in your hand and see what happens, salt. After some time, the feeling is very, it's almost like, if you go to a sea water, go to the beach, how do you feel? You want to take bath, right? After that, it's the same thing. So these are the things that I would like to share. If anyone wants to do a evidence-based practice, it will be nice. So someone says, in my previous institute, we used sterile water for bedridden patients and asked mobilized patients to wash perineum with normal water. I don't know why that discrimination is there. It is not recommended that for bedridden patient you have to use sterile water. There is nothing like that. In that case, we should use sterile water to give them bath also, because they have other, holes through which they can get infection, correct? So I can only say that there is no evidence for this thing. So yes, soap and water, you said that it leaves the encrustation. Even saline also can cause in some patients. So Karishma, your hand is up. Would you like to share something?
Yes, ma'am. Thank you for giving this idea of EBP. Ma'am, actually, we are having a challenge in our organization of IAD, ma'am, incontinence associated dermatitis, which we found mostly for the, loose motion patient, because our hospital mostly receive all CLD patients and CKD patients. And also we found that because, patient, if they're bedwetting, and it is also a risk for IAD. So we have taken a EPP for IAD this year. So, ma'am, I would like to go ahead with this EBP for this catheter care also. I will discuss with, and I think it is a good idea, because we were searching for what EBP we will take, and now this is a clear cut, like with this discussion, it opened the eyes. So I will definitely go and discuss, and we'll definitely talk about EPP. And I have also done the short level course of like EBP. So I had little idea, but I need to learn and read more. And ma'am, definitely this is a very good idea. So I'll go ahead with this EBP, ma'am.
Fantastic, fantastic. So I can give you some people to help you, to guide you.
Sure,
Because
ma'am. I'll require your guidance. Sure,
No,
ma'am.
I
Thank you so much.
people who have worked on EBP. And Beena, she is working in the Middle East. She's telling in abroad, even though we have wipes, we used to clean with soap and water. I can tell you why, Beena. It's only because that is the recommendation from CDC. So in Middle East, all hospitals are like, whatever the CDC says, you have to do it. Yes, that is what they're, and if you actually look at how they do it, is they actually have special solutions which is available only for catheter care. That's what I understood when I was trying to read more about it, how they are showing they have a towel and they put in 4 different places, little of this soapy solution, and they wipe it. You can also go to the YouTube channel and look at it, how they are certifying the certified nursing assistants to give catheter care, how it should be demonstrated. So you can see all this. I did a lot of, I tried to search to find out, what is the best way. So no one is going to stop us from using a wipes, provided what you need to start asking. The first question is whatever the ingredients is there in the wipe is compatible to the material of the Follis catheter. That is what is required to be answered first before you get into using this. Once it is done, I'm very confident that instead of using regular soap and water, using wipes the right way. It is very important because there are steps when you use the wipes. You cannot same like, you cannot use just one wipe and put it all over the area. So definitely there has to be a training. There is a protocol how you will wipe. All these things are there. So definitely great. A lot of people are saying that we are going to work on the EBP. I am excited to, hear. And the question is that how to collect samples from catheter or bag. As I told you, there is no recommendation to collect any urine sample from the bag. Idea is to collect it from the collection port. So you need to have that catheter setup where there is a port closer to the, the regular collection. After that, there is a collection port, which you are supposed to disinfect like you do scrub the hub. So take an alcohol swab, scrub that area, allow it to dry for 30 seconds, then put sterile syringe, and then you can remove the urine. The earlier time we used to take from the Y connection, that was a different procedure altogether. The principles of aseptic non-touch technique remains the same. It is just that the risk of patient getting infection when we access the system is being reduced when we put this, practices. One is the closed loop drainage system. That means you just don't open. Same like for CLAPSI also, they talk about the closed loop drainage system. So thank you, Karishma, for initiating. I can see that more people are, saying that we would like to use. Blessy is telling we'd like to do EBP. So I would like, in case someone is wanting to do EBP, we can make a cohort. I mean, in the sense that we can put 2-3 hospitals together and they follow the same thing. That way, it becomes a, evidence that we can publish. Correct, Dr. Rosalie? Am I right? Yeah. Great. So, Karishma, I think Blessy is one of my student from the infection control program. And who is SF? I don't know. You need to just text me, then I can put you all together and then we can, try to do a evidence-based practice. That's not a problem. And if you are ANEI members, it's even better because this can be done under the umbrella of ANEI and we can get some mentors for you to help you. There are people who are trained in EBP, so we can get mentors. We just need people because you have to get approval from your organization. So whoever is willing, please go and find out whether the wipes ingredients are compatible with Follis catheter material. That's the first question to start. Yes, cohorting is great idea. We will definitely cohort. Thank you so much. Asha Parveen, your hand is up. Would you like to share something? Or by mistake, your hand went up?
Hello, ma'am. Good evening, ma'am. Asha here. So
Yeah.
as we are discussing about using of these wipes, what we are using for the bath. So as of my knowledge, I think most of the that body wipes are containing with chlorhexidine. So which is a harmful to use for a routine catheter care. As you said, betadine, we cannot use it for a routine catheter care right now, ma'am. So only we will use it when we are doing a sterile. At the time of insertion, we are using. I think, I'm not sure. I think because of this reason, the CDC is not recommending, I think. So the usually
will not recommend. See, CDC will not recommend. Now, my counter question, Asha, is that who has given the recommendation to use chlorhexidine wipes for all patients? Are we contributing to antimicrobial resistance? The more disinfectants which are in the environment, it is going to facilitate antimicrobial resistance. The recommendation for chlorhexidine wipes are only, if I know correctly, there is somewhere the recommendation is only for ICU patients. not for all the patients in the hospital. You could be actually, why did the CDC go for soap and water? Before we were using betadine, you should know why they came up with that. It's because they found that we are reducing the natural protective or microorganisms which are there. They are supposed to protect us because our whole body has got lot of good organisms living, trying to protect us. So you don't want that to be destroyed. The same like when you have lot of antibiotics, your normal gut flora gets disturbed. Then you land up getting severe gastroenteritis, right? So that is also very important. Why not get wipes which are used for babies? They don't use wipes for babies and pets which contain any disinfectant, right? They use which is compatible to normal human skin. So maybe these are questions. Very good thought, Asha. So I would say definitely there is no recommendation to use chlorhexidine wipes for all the patients when you're giving bath. Maybe we are contributing to AMR. Again, there is no evidence to prove that because nobody is asking what is the ingredient in the wipes. Bath wipes, you don't need to have chlorhexidine. Chlorhexidine is a pretty strong disinfectant, right?
Yes, ma'am, you're right.
So that's a question to ask now, no? Why am I using? So that's where, I really hope the nurses will start asking questions. What is this material I am using? Why am I using? Is it recommended, not recommended? So get into the depth of anything that you use, whether it is dressing material, wipes, catheters. When you think that patient is having problem, ask more questions and you will find answers, right? So wipes and brands keep changing in hospitals. Get into it, my dears. You should say, this is affecting the patient. Nurses need to be part of it. Before you decide to change the brand or bring anything new, become very empowered. Patients are our responsibility. And if we keep our eyes closed and just receive everything that comes from the store, we are not doing our role as patient safety champions or soldiers or patient advocate, whatever you call it. We are all educated, right? Minimum 3 years, and then we have experience. We are supposed to ask questions. I think it was a fantastic discussion, Dr. Rosaline. It was.
And there's a question on when the patient goes for an ultrasound, we clamp the catheter for the bladder to be full.
Yes.
So is it wrong?
No. That, of course, is a medically.
As far as the circuit is fully closed, we can clamp, finish the ultrasound and remove, not the Euro bag to be disconnected and sending the patient. That is wrong. But the closed circuit is very important. So that's the answer to the question.
Yes. The closed circuit has to be maintained, but you can clamp because there is a medical indication for that. Obviously, if you don't clamp, how can you get the bladder full? Because
Bladder full.
Continue to drain.
There's a question.
Okay.
I hope the question is answered.
Yes. Did we miss
Any
anything?
other questions? Any other things which we missed out?
I think I have looked at most of the questions. Really, I love you guys because you are asking questions and giving answers. Fantastic. We would love to see you again in August when we are going to discuss about hypoglycemia. So I'm really happy, when I see people who are engaging, asking questions, commenting, and it gives me a lot of hope for tomorrow. The future of nursing in India is going to be brighter with all these youngsters asking questions and wanting to do better and more. Thank you very much. Thanks to all the people.
Ma'am, one question, ma'am, last. Ma'am, we do practice normal saline in all the critical care units. We have catheter care set, which has an artery forceps. So we don't exactly put normal saline on the patient. Like we use the artery forceps, and though it is not recommended, but in critical care units, we use a sterile sets, ma'am. Is that okay, ma'am?
There is no guideline. There is no recommendation for that. It's a simple recommendation from CDC. Wash the area as you take bath. They don't even talk about 3 times, let me tell you. If you are taking bath once a day, that's good enough. but observe the catheter site. If it's getting dirty, wash it again. That's all. Just like when we will wash, something like that is only. It does not talk about that. So these are procedures that we are writing for ourselves, for our, what you call, maybe our ease of procedure and plus our worry for our patients. Maybe because of this patient got CAUTI. It is not necessary. We are not even able to prove doing that will reduce CAUTI. We have no idea because there is no evidence. So that's my answer, Maria. Okay. Oh, link for certificate. Sure. Discussing for a long time. I forgot to post the link. Just give me a minute. I will definitely post the link. I can only do it here in this session because only those who are coming here can do that. And please remember, today we do have a little bit of technical glitch. Because of that, you may not get the certificate automatically. One of my ANEI Patient Safety Fellows, Dr. Vijaya Tongam, will take care of it tomorrow. That's what she said. While we were testing the link, there was something that was right. So she will mail it to you because once you give the feedback, she will have all the data. So she will be mailing it to you. Okay. Someone wants EBP course. So I think this is the second question that came today. So let me consult with the Indian Academy of EBP, for which Dr. Vijay George, one of our international ANI member, is the faculty. So I can definitely ask for that. It is working. Please take the link and keep it and put it on another, you have to open new tab and put it there. It will work. Okay. So I hope all of you have copied the link and thank you very much. And we have taken more time. It's because of a lot of discussions. I'm very happy if we take time for the benefit of improving our processes. I have no doubt.
Sorry.
Thank you so much, Dr. Rosaline. That was a very
Ma'am,
energizing.
link is not opening, ma'am.
Sorry, ma'am, and thank you.
See, it is opening. If one person can open, everybody can open. Please copy and put it, keep it somewhere and open it later. Okay.
Thank you.
Thank you. Dr. Rosaline, you are still having problem. We are not able to hear you. No worries. Thank you, everyone, and good night and take care. Shabba khair and see you next next month. We are starting August. We'll see you next month. Okay. Bye-bye.
Thank you, ma'am.
Thank you, ma'am. Bye-bye, ma'am.
Bye.
Thank you,
If you want to
ma'am.
do EBP, please get in touch with me individually. Okay.